All right. Candace, we're back with another episode of One-to-One Nursing. How are you doing?
Oh, I'm spectacular. How about you? It's my favorite time of year.
Indeed. Indeed. Yes, it is beautiful out. And last time I was doing a lot of the speaking, Candace, so I figured I'd take a break and have one where you're doing the majority of the talking. And so we're going to discuss an issue on this episode that I have no idea about. And I've always been curious. In fact, one of the reasons I wanted to do this podcast with you is questions like this one, which I want to know how nurses manage their workload. Are you cool talking about that, Candace?
Oh, yeah. No problem. You want to know what it's like to be me? Is that what you're asking?
Not you, because you're not good at representation. I think most of the folks out there, nor am I. But I want to hear your projection of the quintessential ED nurse taking care of a bunch of sick patients. And the scenario I want to give you, Candace, is you're not in this glorified place where it's 1-to-1 or even 1-to-2 like you might have at your shop. I want to say in most EDs, if they have a couple of sick patients, they're also caring for 2 or 3 non-sick ones. And I think if you could get down to a 4-to-1 nursing ratio for the sick patients at most EDs, you're doing a great job. So let's pretend that you have 2 sick patients and you've accumulated another 2 or 3 sort of sick patients. And so you're carrying like a 4 or 5 patient workload. I want to hear, with that as the context, how you manage that workload. Let's say the most recent sick patient has just come in. You guys have done the swarm, and now things have settled out. The docs have gone off to place orders. You have your one existing super sick patient. You have 2 other semi-sick, and you have 1 brand new critically ill patient. So tell me, what's going through your mind right now? How are you organizing? How does this work?
Okay. So one, I think we should start off with geography. If possible, I think you should have in a 1-to-4 ratio, a zone preference, meaning that the geography that you set up your department to be with the nurse being able to see the most at the most, right? Whether that's a front and a back or a specific room, if you're fortunate enough to have single rooms, like for me, some of my high acuity rooms, the recess rooms can be almost always single. But then our high acuity rooms, if we have to, we can double those. So if you have to do that, I think that geography is super important. You want to work smarter, not harder, right? So being able to be on one zone helps you to have your eyes and ears all over the place. Whereas if you had somebody in the front and somebody in the back, you're bound to forget about somebody, or you're bound to miss something. So I think structuring your space to be more cohesive for the nursing team is super important. And then 2, that we all appreciate the condition the same. So for me, I would focus initially on the patient that just arrived, right? So I would do my swarm method. I would identify what my next tasks would be. I'm assuming that I'm going to deliver medications. I'm going to prepare for an intubation. I'm going to need to go to radiology, right? Because those are the top things that you do in the first 20 minutes, right? Isn't that the prime time for trauma patients, for stroke patients, for MI patients? What are you doing in the first 20 minutes? So the first 5 to 10 minutes is the swarm method. And then the next 10 minutes, which makes about the first 20, the nurse is going to prepare medicinal therapy, get a transport monitor, call radiology, and make a plan. So that's what I would do in the first 20 minutes. Your question is probably going to be, what do I do with the others?
Yeah, that's the next thing to certainly talk about. And then the sick patient you just got, I'm curious after those first 20 minutes. Those first 20 minutes are intuitive to me. You're going to be spending a lot of attention to getting that patient situated and safe and in a good place. But this is still a fresh, critically ill patient. So how are you going to balance? Well, ideally, you would just be able to spend all your time with that new patient until everyone knows what's going on with them and they've settled out. But that's not going to be realistic if you already have another sick patient and 3 others. So yeah, how do you start splitting your time between these patients after those initial 20 or 30 minutes?
Okay. So I think using your technology helps, right? You're going to set your monitor to pull through your vital signs and recycle them for you on a consistent basis. For me, I like it to be every 10 minutes. If the person is hypotensive, obviously 10 minutes is not appropriate. And then I'll do it like 3 to 5 minutes until you can place an A-line, right?
So future Weingart popping in here. So 2 points that came out of that last little bit. Point one, you must, if you are a resus nurse, be totally on the ball about changing BP rep time. That's what Candace was talking about at that last piece. Your blood pressure rep time is generally defaulted to something that will not be okay for a sick patient, something like 30 to 60 minutes. Now, if you have the ability to talk amongst your group, the ED critical care physician lead and nurse lead, I would say that rep time should be defaulted in the resus area. And I hope you have a resus area. We could talk about that on another show, but maybe we talk about it on this show a little bit later. But there should not be patients who are critically ill spread throughout the department. That's just crazy. So in the place where sick patients go, your rep time may be something like 10 to 15 minutes defaulted. And then even if you forget to change it, you're going to be okay. But in most places, it's 30 or 60 minutes. You must change this rep time. Now, as Candace said, something like 10 to 15 minutes is fine for a patient who's sick but not critically ill. If they're critically ill, I want to see a BP rep time of 5 minutes. That's generally what I will set it to. And I make a point to do this myself if I don't know the resus nurses involved. If I'm with a new cadre, a new traveler, etc., I'll change my own rep time because yes, it's a little annoying for the patient to get squeezed that often, but it's also a little annoying if they have really bad blood pressure dips that don't get caught because of a 20-minute rep time. So if the patient starts complaining, that's your cue to make it a little bit longer if they've stabilized. But otherwise, I err on the side of 5 minutes. Candace was saying 3 minutes. That's one thing. The next thing, and this is not something you could do individually. This is something, again, you have to work with your nurse and doc lead for critical care in your emergency department or ICU, but it's worth doing an audit of your entire alarm schema, meaning have the biotechnician print out all of the alarm settings and then go through it and say, well, that alarm's useless. We don't need that. Oh, that alarm's incredibly important. It's not turned on. And then the actual parameters that get you those alarms. What is considered a high heart rate? What is a low BP? What is an arrhythmia alarm you care about and which ones you don't? Because this will allow nurses who are not one-to-one to still now have what is admittedly a lesser stance, a reactive stance rather than a proactive stance. But the reactive stance will now be cued much earlier if every time you hear an alarm in your resus area, people run to the bedside because you've gone through all the alarms and there's no more garbage that should be ignored. Every alarm now is one that's important. If every alarm is important, people start taking it seriously. If we have the standard setup where every alarm, 99% chance it's garbage, we all start blocking out that sound. And as a result, patients become markedly less safe. So there you go, 2 points. Let's jump back in.
So I'm going to assume that you're not at the bedside right now, but rather I could use my technology. So I'm going to set my monitor for every 10 minutes. It makes a sound where I set it so that it makes a sound when the blood pressure finishes, right? It makes a sound when the heart rate goes off or the pulse ox is off or the end tidal. So that would, if I'm doing something, it makes me look up. You have the option to split screens on many of the bedside monitors, whether that's Philips, GE, what have you, where you can look at your other critically ill patient and split your screen. So when we designed our space, I remember you and I went back and forth on the size of the monitor. And I was going with less is more, and you taught me otherwise and said the bigger the better, at least when it came to this. Therefore, I was wrong, admitted that. I admit it now to everybody that's listening. You were right, because I'm able to see very clear what the other patient that I may have, plus the one I'm currently managing that's new at the same time. And then you have to be humble enough to say to your peer next to you, that's what nursing is all about is, hey, these people, I don't think I'm going to be able to do it all for all of them. Can you do this for me? Or can you hang those antibiotics? Or can you check my levo and make sure that it's not empty? Or can you just swing by, make sure everybody's still in the bed and not out of the bed? Because sometimes that can happen. And you need to have that kind of paired nursing. I think that overall, it causes better care for the patient when there's more than one person looking in on their care.
That all makes complete sense. How are you splitting your time between bedside, going to actually see the patient? Now, obviously, if you're going to hang a med, you're going to be there. But let's say there's not a task that's dragging you to the room at that moment. Are you going to the bedside regardless, some certain number of times, depending on the acuity of the patient? How much time are you spending looking in the chart for things like results versus charting? How do you divide your time? Do you have any regimented way, or are things happening more in the moment?
I think everybody primarily uses a rolling cart these days, at least from nursing's perspective. I think if you're still using a nursing station, that's bad care, and just in my opinion, because then you have to take the time to go away from the patient. So that might work for low acuity patients or even some moderate acuity patients, but that's not going to work for high acuity patients. You're taking too many verbal orders. You're missing out on results that are coming back from either diagnostic tests or laboratory, and you're not able to appreciate what is happening in a fluid state. So, one, I chart at the time when I'm in the room. So, geography to me, like I said, super important. So, I will be outside, say room 1, and we have one patient in room 1, and then hopefully I have my other patients in that same quad. And we also have remote monitors in the hallway, which will show me vital signs of every patient in that space. They beep and turn a different color. For us, they don't beep in the hallway because that will in return give you a little bit of alarm fatigue, but instead they turn a different color so that your eye is trained to say, hey, why is that purple? Hey, why is that red? Because it gives you the opportunity to see it on the perimeter and not only inside the room. So I would then complete my tasks, right? Come out of the room because I do typically then need to call other services. So whether that's pharmacy, radiology, what have you, send the labs to the scud. I take my walk back to wherever I'm going as an opportunity for me to do a peek in of what's happening in the other spaces. So I could look up the monitor, I could look into the room, and I try to make a touch base with each one of my patients at least twice an hour. Now, a touch base could be me going in and drawing a lab, could be me going in and giving meds, or could be me just waving and giving a thumbs up, something along those lines. And each one of those will be different based on where I'm going to prioritize my work. So if I'm thinking about giving tenecteplase to an active stroke patient, I need to be at that bedside pretty often. So I probably would do more of the walk by and the thumbs up, or say, we're still waiting for EP to come down and look at your pacemaker, or I'm waiting for the trauma surgeon to come and sew up your lac, and give those short. And then certainly I need to we use a tracking board, right? So I put my tasks on the tracking board. Like I will put Trope 1500, Vanco at 1630, so that I know when I'm looking globally at what's happening in my suite, that I know what are the 3 things that I have to do right there using the electronic record. And it also communicates to my team member, right? So whoever my nurse partner is that day, they could be like, oh, Candace needs a trope in room 5. And she just gave tenecteplase. Let me just quick and go run that. And then the nurse writes done next to it on the board. So I see that and then don't have to worry about it. I think that using technology to its fullest potential really can help you with your time management skills.
No, I love all that. When I was in the ICU, the nurses took ownership of the patient's complete plan. And on rounds, you'd talk about the plan, and then the nurses knew, here's what we're trying to accomplish this day, and they could actually own that stuff. When I came to regular emergency medicine, that really wasn't happening. And the nurses really were responsive to orders, but did not have, because they weren't told and because they didn't ask, the complete trajectory of where we desired that patient to go as a team. And as a result, they were just playing check off the orders. And then the Resus cadre we built, and even before that Resus cadre, the nurses in Resus did own it. And they were doing things like getting a plan. What's the trajectory of this patient? They'd be checking results. They'd know before you did as the doc quite often.
Yeah.
This came back. It's a problem. What are we going to do about it? That's in a completely different level of resus care. So I have to imagine you were primary in instilling that. What do you say to the nurses that are just, my interaction with the patient is I have to pick up whatever orders are there. And if there's no orders, then my care of that patient is really pausing until the docs tell me something new.
Yeah, that's not my style, right, at all. And I think I started training people more in the moderate acuity area to look at the results because it helped drive the throughput. So say you had 12 exam rooms and you had 2 nurses and ideally they had 14 patients, say. That attending had all 14 patients that those 2 nurses had, and they could have some more. So how do I expect that while I'm only maintaining 6 or 7 of them, that you're going to maintain 21 and you're going to know all that this patient has appendicitis or this person has a pons stroke, right? So I always instilled that part of the throughput, which is what every single patient asks every single nurse when they go in a room. What am I waiting for? How much longer do I have to be here? And when can I eat? Those are the 3 things that everybody wants to know. I can't answer those if I don't know what your CAT scan looks like. I didn't look at your labs, and I don't know what your next plan is. I don't know when the consultants are coming. So when we built our EHR, we put things like a yellow star for a abnormal lab or a red star for a critical lab. We did the same thing for radiology, right? So radiology would have a different icon if it was a critical value now, because it helps drive people to know this is something you got to look at if you weren't looking already. So then after we figured that out in the moderate zone, we moved it to the high zone because I would drive part of the care plan for you. Hey, this person, they're not doing so great. I happen to notice that their CAT scan shows a huge pneumonia. Do you want to think about maybe we should consider some BiPAP or we want to try a second set of antibiotics? I'm concerned their blood pressures are super soft. Do we want to think about just having some backup vasoactive drips if we need? I know they're in failure. And driving that. But if I didn't know that, it just takes away the time to get the patient the end care, because you would come and be like, Ken, did you see that? This guy's got a pneumothorax. And I'll be like, oh, okay, let me go get the stuff for the chest tube. Let me make sure we have push dose epi if we need it. Let me go get them some airway supplies. But if I found that based on me just reviewing results and charting all of my stuff, then we could have an informed conversation together. And it made my work more meaningful because I wasn't waiting around for what I should do next, but rather being proactive in rounding on the results of my patients. So just like you're rounding on new orders or you're rounding to put in new vital signs or an INO or whatever's going on, you need to round on the results. When adding that to part of your hourly assessments helps you to be ahead of the game and not behind it. Again, I use technology to help drive the ones that were critical.
No, I love all that. Now, there's always a trade-off in many places between the number of RNs and then the number of RN extenders, like clinical associates, LPNs, and I think depending on that, nurses could carry a much larger load. So what is your philosophy on that in terms of hiring? Do you hire more RNs? Do you hire excellent RNs and then more of these extenders? What is the balance for this for resus patients?
Yeah. So I am more of I hire more RNs for the critically ill patients. I don't care if you're experienced or a new grad because I'm going to give you all the tools to put in your toolbox. So it's irrelevant to me, believe it or not, one or the other. Somebody took a chance on me when I was a new grad, and I appreciate that, and I will always give back to that population. I do give them a longer orientation because I want to refine their skills, but some of them wound up being the best staff I ever had. And almost all of them go on to be advanced practice nurses, which I think makes the healthcare profession better. The reason that I don't hire LPNs for the recess space is their scope of practice is super limited. They're not allowed to give IV push meds. They're not allowed to hang first dose antibiotics. They're allowed to check the blood, but not hang the blood. They can't titrate vasoactive. So I felt like while they could draw some laboratory samples for me or help with vital signs, EKGs, and transport of patients, I could get that out of a clinical associate the same way. And there was never that I can't do this and you can do that, right? Like I felt like you're a nurse or you're a clinical associate, right? You're not like it's gray. And that is also gray for my provider partner, right? You're like, I just asked them to do that. But do you remember Candace could do this? Lena can't do that. You don't remember that all the time, right? And for me, and I think there's LPNs are super useful in my front end, super useful in the moderate acuity space. I just don't find that the value for them personally is in the critical care space because there's so much restriction on their scope of practice. And that might just be here in New York State. I don't think it is, but that's the difference between really having different types of nursing autonomy.
Okay, this one might be controversial. It might piss some people off, but I don't think so. I think this is pretty safe. I think nurses have enough to do without adding the burdens of charting. So in my ideal world, nurses would be charting objective things that need to be there, fluid balance, the medications they administered and whatever, and then relieve them of the burden of charting for most of the other stuff, because I think it takes a lot of time away from them at the bedside, and I don't think it helps the overall care. And in some cases, from a liability perspective, it actually hurts it. And so what is your take on this, Candace? If you could just cast with a magic wand a spell to make things exactly as they should be, how much charting would nurses do?
Yeah. I don't know. I agree with you on some parts of it. Like it definitely takes a lot of time, especially if you're not skillful at it. And then on a side part, if I write things that are not what you write, what always comes to mind is a vascular patient and their pedal pulses. Those will always burn us because I think those are subjective, right? Like you might think something different. And how you're palpating the pulse may be different than me. And we've talked about that before. So I think those are a challenge. I wish that you could just dictate a note, to be honest with you, and nurses do not do that. I know that some physicians use a dictation and types the note for them. I think that if a nurse could do that would be the best utilization of their time.
It scares me. I got to say, because I think that would make things even worse.
Why?
Because it's so easy to put just a ton of stuff on the chart at that point. And I think, again, look, if there was no malpractice, then yeah, let's do it. And we're always thinking best case scenario, okay, just going to get all this true information. But I don't know. Just don't see much gain to any of the extraneous charting.
What electronic health record are you using now?
Citrix.
So the same as me?
Yes.
Okay. I guess this question is for people outside of us then, right? What does Epic look like?
It doesn't. I've played with Epic at other hospitals. It doesn't look that different.
They're
all essentially the same crap. You could build them however you want. It's not that I don't want to give free expression. It's that every minute charting is a minute away from the bedside. And it's bad enough the docs have to do it. So if it's superfluous, I would get rid of it is what it comes down to. And what's not superfluous is all of the nursing tasks done, all of the nursing assessments. I think those have to happen. But I guess just philosophically, I'd say strip it down as far as you could go to keep nurses at the bedside. It's bad enough docs have to spend 50% of their time or more at the computer. I just really would love nurses to not have to do that as well, because they are the real connection to the patient. Nurses are the ones at the bedside who are catching the badness happening and making sure that they are actually picking up on the fact that the patient just self-extubated. So yeah, anything taking them away from the bedside scares me.
So I agree with that sense of less is more. So I've changed the policy for us that we only have to chart an assessment Q shift. Now, Q shift can be 12 hours so that it's anytime the caregiver changes. Because I think that that portion of it tailors it down. And then I think that it reduces. We used to have to do them every 4 hours. And
Yeah,
that's
no, that's so much better.
too much. So I think if you do a Q shift, and then if there's no change in the assessment, that's why I would dictate the note. I would just say I accepted patient from Dana, patient presented for XYZ, pending cardiology clearance and planned medicine admission, right? Like then call it a day and that's it. So I think it gets, for me, it's charting by exception. That's my general rule. So while you cover 8 systems of the body, most of them will say none reported because you're only charting the things that are necessary. Nobody cares about the unnecessary things. You just need to streamline it to be charting by exception.
I
The
love that.
difference is like when I put in an IV, it's like maybe 8 clicks. When you put in a line, you have to write a procedure note. You need the timeout. It's so much more. Right? So I take the simpler route of 8 clicks, but it's charting by exception. So I think that's really the answer. And it should be charting only when the caregiver changes. So you don't need to have 9,000 assessments that say the exact same thing. Now I put a part in the nursing documentation that says SOC reviewed for standard of care, and then it's peripheral IV, physical assessment. So you can write no change, right? So that I noted there was no change in this patient's status, and I've been here with this person for 14 hours. So here's my initial assessment, and I click twice to write no change, not doing the whole thing all over again.
I love it.
What do you think about that?
Oh, I think as soon as you said only once per shift, I'm like, alrighty, this is better than every ED out there. That's fantastic. I think that's a huge change forward. So that's fantastic. One of the major inefficiencies is getting your patients upstairs once they've been admitted. What tips do you have for units and ICUs that don't want to take patients?
Okay. So, I have a very good relationship. I've said this before with my partner in the medical intensive care unit. Her name is Haley, and I love her. We've had tea and coffee with her and cookies all the time, every holiday. Well, I do not have that relationship with my colleagues in the surgical intensive care unit. I worked with Haley, right? Because we needed to be together as a team. And I, one, created open dialogue. I don't always want to say that the ED is busier than the ICU because then I'm being insensitive. While I may always think that in my heart, it might not be true, right? So I made a plan with Haley that what we would do is when I gave report, we would say, are you coming down or do you need me to bring the patient up? So the expectation was the ICU came down because their nurse to patient ratio is always 2, right? The ED, your nurse to patient ratio, you have way more than 2 patients every single day, every minute of your shift. So I would always say, are you coming down or do you need me to come up? That's because it made me offer my services. And they knew 95% of the time when they said, I need you to come up because my other patient's on CRRT, I would bring that patient up. But 95% of the time, they will come downstairs. If I can't give report, that's my surgical intensive care unit friends. Never want to let me give report. The bed's dirty. I don't know. The curtain is turned to the west instead of the east, whatever the case may be. Okay. I use the famous terms of, I'll be up in 15 minutes and we can discuss it at the bedside. And they knew that the expectation from Candace was that we gave bedside report. So you either take the patient now or I'll be up there. And if I go up there, it's almost always not the friendliest response on either team because I'm frustrated that you wouldn't give me the opportunity to talk to you. You're frustrated that I didn't care that the curtain was to the west versus the east, right? So that's step one, is engaging the ICU team at the handoff period to come into your environment, because that perspective and looking at it makes a huge difference.
Let me just make sure I understand here. So the SICU is saying they can't take the patient yet because the bed is still dirty. And you're saying you'd go up there in 15 minutes. Was that with the patient or was that just you?
Yeah. No.
So they're saying, no, you can't come, but you go anyway?
Yes.
How do you?
Because the bed is clean.
But how do
they
you?
just said
How do you
the
not
nurses,
have them writing
I don't know,
complaints
in the bathroom,
saying the patient was brought
on a
up
break.
even though the bed was still not ready for the patient?
Yeah. So our electronic tracking board tells us that the bed is clean, occupied, or dirty.
Okay.
So if it's dirty, I won't be a witch and say I'll be right there. But when that bed is available and you tell me you're in the bathroom, you had to go get a cookie, I don't know, the curtain doesn't look good enough, I can't find a pillow, whatever the hell you're saying, I'm coming anyway.
Gotcha.
It's happening. Like, this is my warning that my presence is going to join you on your floor.
Now that's you. You're in a leadership position and you're...
Staff do that.
That was my next question. So can just a brand new nurse working resus in the ED get away with saying, look, okay, you have 15 more minutes to get that curtain the way you want, but then I'm up there?
Yes, that's what throughput is all about, right? If I take off my clinical hat and put on my administrative hat, moving patients to their inpatient beds is a major priority and a metric for emergency medicine, right? So every time your door to depart is beyond what it should be, you need to reflect on that's a process failure. So for me, I created the 15-minute rule. I gave you 15 minutes. You're not coming. You're becoming a barrier. I'm coming upstairs. You had your time. It's happening. So we have this standard 15-minute rule when people refuse report, right? We're coming. But to have a softer, more bees with honey than bees in vinegar approach, I use the do you want to come down or do you want me to come up routine? So I have two different methods, right? I could tell you that do you want to come down goes much smoother. There's never pushback. There's always engagement. And there's let me just walk in their shoes for a second, right? Oh, this is terrible down here. It looks like a war zone, right? Versus I have a lot, my patient's getting intubated next door, or I'm in charge in the ICU today. Can you come up? It creates that better environment. And then we have the side that people just don't want to, nobody wants more work. Let's just call a spade. So if I could drag it out for 45 minutes to an hour, I'm going to do that. So we don't allow that. We got a 15-minute rule, right? It's 15 minutes and I'm coming. And let's be real.
So one of the common things that just shuts down the ability to get patients upstairs is they say they have a code in the unit. And that could be like 2 hours of not taking any patients for the entire nursing staff of the SICU or the MICU. And it never made sense. That's not how we run codes. You don't have every nurse in an ICU in the code, and codes don't go on for 2 hours. So how do you deal with that one? That seems like a tougher one when they say that, to say, I'll be up there in 15 minutes. Were you still pushing things as hard?
I think I don't push it as hard if they say that, but I'm definitely not giving them more than an hour because I would have heard that code, right? It would have been overhead. I would have heard it. I could appreciate it. You know, when they say they have a soft, rapid response, that doesn't exist. If you needed people at the bedside, it shouldn't be soft. Okay? So, no. And like you said, you need all 11 nurses at the bedside for a code. That's too many people. Let me teach you how to do it better with less. Right? Come on. There's no less than 4 physicians and 11 nurses. That's a small group party. No.
All right, Candace, what have we missed? What advice do you have out there for, let's say, a brand new nurse who is like, how do I take care of 5 patients when 2 of them are critically ill and 3 of them are pretty sick? What advice do you have for these folks?
Don't be afraid to ask for help. It doesn't mean that it's a sign of weakness. If anything, to me, it's a sign of strength. You can't do everything by yourself. And if you don't know something, then ask, because not being able to think before the orders come through or make differential diagnoses for your patients means that you're not following the right plan. And that means you and your doc are not on the same page, right? And being on the same page means that together you could care for patients faster and better.
Yeah, the other thing you've always had, Candace, is nurse educators. There's at least one of them on shift at all times as a clinical resource, so that if there was an order that you just haven't done for a long time, the dabigatran reversal, which is ridiculous, and then there was always someone you could ask. And even in places that don't have that bounty of a nurse educator, in general, the charge nurse is someone, who is usually more experienced and could be helped out, rather than just trying to muddle through something that could result in bad outcome if you are not doing it right.
Yeah, I agree. I've always had the model of having an educator free, meaning that they are in the unit. Now, they can be orienting a new nurse, but they don't say, oh, I'm not the educator right now, I'm the preceptor. That's not what I believe in. I wear 9 hats, so does everybody else. But I think that is always the resource for people, and it makes them more comfortable. So you need to find your resource or create a resource pattern. Now, that could be in the form of a book that you have protocols. It could be a form in what we did for my doctoral project, right? Just in time educational videos that you watch a video for 4 minutes and you're like, "Ugh, I could put this TVP in blind because I just watched Candace in the bathroom do it on YouTube," right? Whatever's happening. So you need to create what your resource is. It can be fluid in videos. It can be dynamic in protocols that you keep up and manage, or it could be in a person, which is to me my best model or my favorite model, but that's expensive, right? No nurse doing no assignment is cheap for an organization. I've been lucky enough to build that model. And they also, when days like today, where I had a large amount of sick calls and 55 boarders, that educator worked as a nurse today because that's what we needed to do. So you do get your bang for the buck. But if you couldn't afford that, because maybe you're in a rural place, that doesn't mean you shouldn't have a resource plan. And it can be documents versus videos versus a telephone call or a physical person.
Hey folks, Future Weingart popping in here. So this is kind of a soapbox issue for me, but we started the show off with the idea that you are taking care of 2 sick patients and 3 not so sick patients, but I just don't think that should be happening. And I know it is the standard in most places, but I understand that even though the ideal would be really sick patients get 1-to-1 nursing, title of the show, 2 not so sick critically ill patients could get 1 nurse together, so 1-to-2 nursing. But if you don't have that, and most places are not, I think the ideal in those circumstances would honestly be 1 nurse for 3 critically ill patients, 1 nurse for 4 critically ill patients, rather than having a nurse with 1 or 2 critically ill patients and a whole bunch of not sick ones. And I say this because I've tried both models, and the model that works better is the model we used to have in New York, where we had a room with 4 sick it was a critical care unit. We had 4 bed slots for non-trauma patients. We had another set of slots for trauma patients. But for the 4 non-trauma critically ill patients, there was 2 nurses there. So a nice 1-to-2 ratio. But they would go on break and they'd have to break each other and cover their own patients. So for, at least 3 hours of the shift, it was just 1 nurse for 4 critically ill patients. Now, it worked fine because, 1, and this is the key, first thing, geographically, those 4 patients were all in 1 room. They weren't separate rooms that the nurse was covering. It was 1 room with curtains separating those beds. And so you'd leave the curtains open unless there was a privacy issue for that patient, meaning you could see all 4 patients from the desk that we were all sitting in, docs and nurses. It was no problem at all to manage 4 critically ill patients for 1 nurse. And if we got multiple simultaneous resuscitations, then of course we'd bring in a nurse from outside. They'd leave their assignment and they'd come and help during that resus. But for just the management of those critically ill patients, when they weren't getting resuscitated or they weren't getting simultaneous intubations, 1 nurse for 4 critically ill patients was fine. Now, it required the docs to help out with a lot of traditionally nursing-like tasks, but I would markedly prefer that model, one nurse for 4 patients, all geographically in the same place, than that same nurse with 1 critically ill patient and 5 non-critically ill patients, which is, I think, the standard, and it doesn't work. That critically ill patient will get the short shrift every single time because they're the ones not making noise. They're intubated or they're just zonked out, and so they don't complain, and they're the ones who get the least amount of care when they should be getting the most. But that requires that you have a geographic location for your critically ill patients, which is another thing I see the opposite being done at so many hospitals. And if the hospital tells you that we resuscitate in every bed in the ED, what they mean to say is we give shitty resuscitation all across our ED, because you cannot do good resus and critical care in every bed in the ED. They are not suited for that. Unless, I don't know, maybe there is this mythical place that has huge resus bays as the standard patient rooms for every single patient room. But even that would be torture. You'd be walking 2 miles between one end of the ED and the other. And anyway, those don't exist. And resus bays and critical care beds should be big, big rooms. You need space to do sterile procedures. You need space to have a team resuscitating. You should have a designated place in your ED for super sick patients. And that's where they should be taken care of. And there should be multiple beds geographically in that same place so that one nurse could take care of a bunch of those patients. If you could resus in every bed, you'd resus in no beds. Show me a place that's different. I promise you, they don't have the same equipment. They don't have the same setup. They don't have the same space in every bed in the ED in order to take care of those sick patients. So put them all in one place. Or if you want to have different resus areas for each zone, okay, I don't think that's ideal, but it's better than the alternative of every bed is a resus bed. And have a space for those sick patients, and then allow a nurse to take care of those patients exclusively rather than splitting with non-sick patients. And I promise you, your care will get better. All right, Kenneth, we're out of time, so I guess we will say goodbye. And if we haven't hit anything that the listeners have as tips or advice or questions, then just get in touch with us and we'll put it in the next show.